Hello everybody. If this is the first time you are watching my YouTube channel, let me introduce myself. I'm Farshad Tahmasebi. I'm consultant obstetrician and gynecologist. In my YouTube videos, we talk about different gynecological topics, break them down into short videos. We go through difficult topics and repeat them in many different ways to make sure you understand and get a good grasp of the topic. We teach you the way we have learned and strive to make you more confident practitioner. I believe if you know the reason behind why you do this test, why you interpret tests like that, why you need to order this test, you can provide an excellent care for your patients. If you would like me to discuss any topics in more details and from another angle, please let me know and we'll make sure we will provide that video for you. Last but not least, make sure you hit the subscribe button and turn on notifications. This is the third video of endometrial cancer series. I hope you have watched the first two. We all know, or you know now, endometrial cancer is the most common gynecological cancer. What we don't know, what we have to know when we sit in the clinic in front of the patient, and what we need to discuss, or which numbers or figures we need to know. In my YouTube channels, we talk about endometrial cancer. I walk you through step by step about numbers, statistics, research, and all other stuff I think we should know. Let's recap before we start third episode. The incidence of endometrial cancer has increased significantly in the last 30 years due to obesity, increasing life expectancy, and tamoxifen. Endometrial cancer ranks highest amongst all cancer associated with obesity. But with timely diagnosis, we can offer curative treatment. Curative treatment is important. Lifetime risk of endometrial cancer is 3%, in an obese woman is 9%, and Lynch syndrome 40 to 60%. We discuss mechanisms through which obesity drives endometrial carcinogenesis, excess estrogen, insulin resistance, and inflammation. In part 2, we discuss the cutoff score of endometrial thickness for initiating investigation. We discuss 2 systematic reviews and sensitivity, specificity for 4 or 5 millimeter endometrial thickness as a cutoff score. We also looked into high-risk group of patients for developing endometrial cancer, Lynch syndrome, and women who are taking tamoxifen, and discussed those in more details. Just quick reminder, Lynch syndrome is autosomal dominant, increase the risk of both type 1 and type 2 endometrial cancer, and screening should start at the age of 35 with both transvaginal and endometrial biopsy. Tamoxifen increase the risk of endometrial cancer in postmenopausal women up to 3-fold. It can induce subepithelial stromal hypertrophy. I know it's quite complex thing to remember. In part 3, I would like to discuss how we can prevent or reduce the risk of endometrial cancer both in general population and also high-risk groups. such as, again, Lynch syndrome and women on tamoxifen. Let's start. Let's carry on with endometrial cancer and prevention in general population. We know that obesity is highly associated with endometrial cancer, and as a result, maintaining a healthy body mass index is likely to reduce the risk of endometrial cancer. How we can achieve healthy body mass index with moderate physical activity or bariatric surgery. We know that every 5 kg per meter squared increase in body mass index is increase the risk of endometrial cancer up to 60%, and bariatric surgery in a right patient can decrease the risk of endometrial cancer up to 7-fold. As a result, tackling obesity is a logical first step to endometrial cancer prevention, and obese women who lose weight through dieting have been shown to lower their serum estrogen and testosterone levels while increasing insulin sensitivity and sex hormone binding globulin, and maybe it's one of the reasons that losing weight can decrease the risk of endometrial cancer by lowering the level of hormones and increasing sex hormone binding globulin. Women should be advised to undertake at least 20 minutes of a moderate intensity exercise sufficiently intense to raise the heart rate. It's important to raise the heart rate 5 times per week in order to prevent endometrial cancer. Regular physical activity reduces the risk of endometrial cancer by 30%, with even greater benefits for those who undertake higher intensity exercise or greater duration. Regarding morbidly obese women, when BMI is more than 40, bariatric surgery is an effective means of reducing the risk of endometrial cancer. But it's important to mention that NICE, National Institute of Clinical Excellence, does not currently list cancer prevention as an indication for bariatric surgery. Remember, young obese women should be advised about contraceptive choices that reduces endometrial cancer risk, and levonorgestrel releasing intrauterine system is associated with a 54% reduction in endometrial cancer risk. Also, we know that combined oral contraceptive, when they have been used for more than 5 years, can reduce the risk of endometrial cancer up to 50%. But remember, obesity and having multiple cardiovascular risk factors are contraindications for using combined oral contraceptive, and those patients should be counseled properly, and the safest option should be used accordingly. In my previous video, we already discussed about 2 high-risk groups of having endometrial cancer: women of tamoxifen, which have 3-fold increased risk of endometrial cancer, and also Lynch syndrome, which increases the risk of having endometrial cancer up to 60%. As I have already discussed, we start screening for Lynch syndrome from the age of 35 with both ultrasound and endometrial biopsy, and we can offer them risk-reducing hysterectomy when appropriate. And in tamoxifen group also, we should routinely question them at breast cancer follow-up visits about the symptoms of postmenopausal bleed. I hope you enjoyed this short video, and please leave your comments, and I will get back to you as soon as possible.